Welcome everyone, and thank you for joining us this afternoon for this forum on understanding addictions. My name is Farah and I will be your MC for today. We'll start with some housekeeping and then acknowledgements. If you haven't already done so, please turn off your mobile phones or put them on silent. If you need the restrooms, they are just down the corridor to your right, and in case of an emergency, the muster point is across the oval. I'd like to acknowledge that we are meeting on Noongar land and to pay my respects to the traditional owners of this land and their elders past and present, and to their culture. I'd also like to acknowledge our sponsor today, the Melville Baha'i community. I'd like to extend a warm welcome to you today on this particularly cold and rainy day, and to also our audience on live stream for taking the time to join us for this forum as we collectively learn about the topic of addiction. And of course, I'd like to thank our panel speakers who will share with us some of their professional and personal experiences on this important topic. The format of this event is such that each of our speakers will talk for about 10 to 15 minutes, and then we will open for questions to the audience. The program today will be video and audio taped, and the material will be shared on Mind and Soul Matters podcast, and some of the photos and materials will be used on social media platforms. You'll also find a number of previous forums presentations on the Mind and Soul Matters podcast. Today's event is part of a quarterly series of mental health and wellbeing forums where we explore relevant topics with the help of expert panel members. Baha'i communities all over the world are working to engage in social discourse on topics that are impacting our communities and society at large. When it comes to understanding addictions, there is a growing recognition that addiction is not simply a personal issue. It is a complex public health crisis, one that touches individuals, families, and communities across every region and background. In Australia, the Department of Health has found that 1 in 6 Australians have a drug addiction, and 1 in 10 have an alcohol addiction. This means that there are over 2 million people in Australia suffering from substance addiction, and according to the World Health Organization, more than 35 million people worldwide suffer from drug use disorders. Yet only 1 in 7 receive any form of treatment. But addiction is not only about substances. Behavioural addictions like gambling, gaming, or compulsive internet use are on the rise as well, particularly among adolescents and young adults. These numbers are not just data points. They represent lives, families, and impact on communities. They remind us that addiction is not rare and it does not discriminate. It affects people from all walks of life, across gender, race, income, and education levels. And yet, despite the scope of the issue, stigma remains one of the biggest barriers to seeking help. Hence the importance of these type of conversations we are having today, to enhance our understanding and remove judgment and stigma. With that, I would like to introduce our first presenter, Dr. Neda Meshkin. Dr. Neda Meshkin is a GP and practice owner. She has over the last 26 years worked in her own general practice, where she now leads a team of 30 healthcare professionals and support staff in a community-based, multidisciplinary environment. Her practice has won numerous awards, including the WA General Practice of the Year Award of the Royal Australian College of GPs, and second place national awards in quality in general practice. Very impressive. Neda's training before family medicine included a master's in public health with early works in addictions and behaviour change, as well as a residency in preventive medicine, which has given her a community lens to the work she does in her general practice. Neda is passionate about patient care and has enjoyed caring for, at times, several generations of a family in her practice. She finds joy in her roles as wife, mum, and grandmother, and in opportunities to serve her community. Neda finds inspiration for her work and life from the teachings of the Baha'i faith. Please welcome Dr. Neda Meshkin.
Good afternoon, everyone, and thank you for the introduction. So the first time Jenny came to see me, she was in her mid-20s. Like many others, her early visits were for everyday health issues: asthma flare-ups, skin rashes, a knee injury. It wasn't until her 10th or so visit, over a few years, that she began to share something deeper. She started disclosing self-medication with prescription drugs, use of illicit drugs, and excessive alcohol use. In time, she also shared a heartbreaking history of childhood sexual abuse from as early age as 4 while in foster care. Her mother was unable to care for her due to her own struggles. Over the past 25 years, Jenny continues to come to the practice, navigating addiction, trauma, relapse, recovery, and the daily efforts of staying afloat. She's given me permission to share her story, though I've changed identifying details to protect her privacy. As a general practitioner, I've had the privilege of glimpsing into people's most vulnerable moments across all stages of life. And through that lens, I've learned that addiction is rarely about a lack of willpower. It's deeply intertwined with personal history, trauma, and pain. Today, I hope to shed some light on addiction, break a few myths, and give you some practical tips on how to support someone who may be suffering from an addiction. Addiction affects more people than many realize. Whether it's alcohol, drugs, gambling, smoking, or other, it doesn't just impact the individual, but also their family, friends, and the entire community. The DSM-5, our standard diagnostic manual on mental health, doesn't use the word addiction as a formal diagnosis. Instead, it refers to substance use disorders, defined as patterns of substance use leading to significant distress or impairment. It outlines 11 criteria across 4 domains: impaired control, social problems, risky use, and physical dependence. Oops. A person is considered to have a severe substance use disorder, or what we might informally call an addiction, when 6 or more of these symptoms are present. So some examples of these 11 symptoms include wanting to cut down or stop using but being unable to, continued use despite social or interpersonal problems, and using to avoid withdrawal symptoms. Dr. Gabor Mate, a former family physician and now an internationally recognized voice on trauma and addiction, describes addiction not as a disease, but as a response to pain. In his book, In the Realm of Hungry Ghosts, he asks us not just to treat addiction, but to understand it. He suggests that unresolved trauma leads people to substances, not for pleasure, but for relief. Relief from loneliness, disconnection, and the absence of love or purpose. he also challenges us to see how entire systems, from medicine to media to commerce, operate in ways that mirror addiction, always seeking more, never satisfied, and often disconnected from meaning. So as a friend or family member, you may recognize that someone is experiencing a struggle with an addiction, not just by observing the substance use, but through other more subtle behaviors. These can include changes in their mood, becoming more secretive, withdrawn or irritable, increasing financial problems, neglecting responsibilities for school or work, poor sleep, or other signs of poor health and self-care. One useful lens for understanding risk of developing an addiction is to think back to a person's early years and the concept of adverse childhood experiences, or ACEs, as we refer to it in clinical practice. Adverse childhood experience, or ACEs, include physical, emotional, or sexual abuse in childhood, neglect, or growing up in households with addiction, mental illness, domestic violence, or incarceration. ACEs are strongly associated with poor mental health outcomes, chronic disease, and addiction. And the more ACEs a person experiences, the higher their risk. Even what might be considered as common life disruptions, such as divorce, loss of a parent, or feeling unsafe at home, can increase that risk. Jenny's story illustrates this. Her early trauma wasn't just a background detail, it was the foundation on which her adult struggles were built. That brings us to a critical misconception and myth, the idea that people with addictions can just say no. This oversimplifies what is in truth a deeply rooted and complex struggle. Interestingly, though, just as ACEs increase the risk of addictions in adult life, the opposite is also true. That is, positive childhood experiences can build resilience, like feeling safe, having supportive adults around, and belonging to a community. These protective factors reduce the risk of addiction, even in the face of extreme hardship. In general practice, offering trauma-informed care is essential in managing a presenting patient who comes for help. This can include things like creating safe environments, offering hope and stability, building trust, and connecting people to supportive communities. Jenny once told me that what kept her going during her darkest times wasn't any one treatment, but the consistency and safety of our clinic, the sense that someone cared without judgment. It took her time to build trust in our team, but once done, it helped to anchor her care and support over the years. As a friend or family member of the person who's suffering from an addiction, it's key to approach them without judgment, without the need to probe for the reason for their addiction, as discussing past trauma can actually be quite triggering and unsettling for a person. Avoiding shame or putting blame, but instead encouraging them to seek help from a professional. Also, setting clear boundaries for yourself too, as the impact on carers can be quite significant. Offer support, connection, and check in with them regularly. Let's now shift to the clinical management of addictions, especially the more chronic, long-term presentations of addictions like Jenny's. One helpful model from Prochaska and DiClemente's Stages of Change model is what I will refer to today. This model encourages the clinician to assess where a patient is at in their change journey, and this determines what help is offered. The stages of change can be described as the first stage of pre-contemplation. In this stage, the person has not yet recognized a need for change and has no interest in stopping the use of the substances. The second stage is contemplation. The person is beginning to think about it, considering to stop or reduce their use. The next stage is preparation. They've decided they want to change, and they're making some plans to get ready for that. Next is action, where they actually make the change. And then maintenance, where they try to sustain it. And then, often, relapse, which isn't failure, but a step in the journey. In fact, people who relapse and try again are often more likely to succeed long term. As clinicians, our role is to identify where someone is on this continuum and help guide them forward. Not push, not shame, but support. There are some very specific strategies that we can use depending on what stage the person is at. I'd also like to touch on addictions from a Baha'i perspective. From a Baha'i point of view, the foundation of healing includes seeking help from competent physicians and treatments based on science, leading a life of spiritual purpose, and connecting with our higher selves through daily prayer, meditation, and reflection. For example, drawing on a prayer from the Baha'i writings, one can pray, "O thou provider, O thou forgiver, grant us thy grace and thy loving kindness, thy gifts and thy bestowals, and sustain us that we may attain our goal." Spiritual practices such as prayer help many find purpose and meaning, two essential elements of recovery. This is echoed in programs like AA or locally Shalom House, where belief in a higher power and a supportive community are central to the healing process. The Baha'i faith also places deep importance on the family as a cornerstone of a healthy society, another layer of protection and support in the journey of recovery. Finally, we're reminded not to judge. As one Baha'i teaching says, "Breathe not the sins of others, so long as thou art thyself a sinner." This principle is deeply aligned with trauma-informed care. Meet people with compassion, not judgment or condemnation. So in summary, addiction is not a simple choice. It's often a response to trauma. Understanding ACEs, or adverse childhood experiences, help us see the roots of addiction in many cases. Supportive care, grounded in empathy, continuity of care, safety, can help people heal. Spiritual frameworks, including Baha'i teachings, offer tools for reflection, meaning, and community support. We each have a role as GPs, family, friends, or fellow community members in supporting those struggling with addiction. Organizing events like today, creating safe spaces for conversation, and challenging the stigma and myths are all steps forward. I hope today's talk has offered a glimpse into the core of addiction and into the kind of care that can truly make a difference. Thank you.
Thank you, Dr. Neda Meshkin, for that wonderful presentation. I'm sure you've taken some gems from that, as have I. I found it really helpful that in terms of reframing trauma as a lack of willpower to a response to pain. So that helps us improve our compassion and hopefully reduce stigma and judgment. A response to pain. Thank you very much. I'd like to now introduce our next presenter, Orla Peoples. Orla is a senior social worker with over a decade of experience working across Western Australia's health, justice, and community sectors. Originally from Ireland, and you'll get to enjoy her beautiful Irish accent, she has spent the past 11 years supporting women and families facing significant and often intersecting challenges, including substance use, mental illness, trauma, and homelessness, many of whom also have involvement with the child protection system. Orla has worked extensively with pregnant women and mothers affected by substance use disorders, offering support in navigating complex systems while addressing multiple layers of vulnerability, Orla brings a trauma-informed, compassionate, and client-centred approach to her work, grounded in deep clinical knowledge and a strong social justice lens. Orla has taught social work and counselling students at Curtin University and Edith Cowan University, and is passionate about shaping the next generation of professionals to be compassionate, client-focused, and values-driven. Currently, Orla runs her own business, and I love this, offering baby massage and hypnobirthing classes, supporting parents to build early connection, emotional regulation, and secure attachment. Her work reflects a strong commitment to improving infant and parental mental health, particularly for families who have experienced trauma or adversity, and to providing all babies with a calm, connected start to life. Isn't that beautiful? Please welcome Orla Peoples.
Thank you for that lovely introduction. And thanks for having me here today. So this is a topic I'm really passionate about, so really happy to be here talking about it today. So I just thought I would start off with what are the most commonly used drugs in Australia. This study was done over a 12-month period, and people were reporting what had they used in the past 12 months. So we can see alcohol clearly stands out, as 80% of people in the community responded to say that they'd used alcohol in the past year. So we know that we hear a lot in the media about methamphetamines and that's, you know, the most used drug in the society. It's not. It's actually alcohol, and the percentages really clearly tell us that here. So you can see cannabis is next at 11.5%. Then we can see NANGs, which might not be common for everyone to know about, and that's nitrous oxide, and that's really commonly used between the teens in the community at the moment, and it's something that's used commonly during childbirth, so gas and air, or during dental procedures, and it's actually really common amongst teens to use that to seek a high, really, in the community. WA's brought in really quite strict rules now around how sourcing that and how you source that so that it's not so available for young people in the community. Non-medical use of pharmaceuticals, which Netta mentioned, is really quite common. And we can see methamphetamine is quite low down the list here at 1.4% of Australians in a year period had used methamphetamines. But we see a big representation in who sought treatment. So 30 to 40% of people in treatment had sought treatment around methamphetamine use. So just some interesting stats to get started with. So what are the reasons people use? So Ned has already talked about the stress and trauma. Some other reasons why is that peer pressure, especially amongst young people in our community, social and environmental influences, accessibility and normalization. So that's a huge one with alcohol and cannabis in the community, that it's easy to buy. It's almost popular because it's seen as to be cool to drink alcohol among young people, and it's advertised as something that's fun, really. Mental health, we see people are often treating themselves, self-medicating by using drugs and alcohol. Cultural and historical factors and generational trauma is huge, and really using substances to manage that. Experimentation, and then economic and life pressures. So people, might not have financial stressors and are using drugs and alcohol to manage that. So we often see clients who have AOD issues, which is alcohol and other drug issues, have got other complexities as well. So some of the things we might see presenting are mental health disorders. Alongside that, depression, anxiety, PTSD, bipolar disorder, psychosis and schizophrenia. Physical health issues, liver disease, cardiovascular problems, respiratory issues, and infectious diseases. And social environmental factors, homelessness, child protection involvement, justice system involvement, and domestic and family violence. And we also see polysubstance, which is using many different substances at the one time. So I think this slide really represents for me the importance of multidisciplinary working. So if Netta's treating the physical health concerns and maybe the mental health concerns, if the homelessness has not been addressed, that person really sort of isn't being wholly supported, isn't getting that full wraparound care. So we really need to be working as a multidisciplinary team and to treating people really effectively. So just an interesting stat that 80% of people in alcohol and other drug treatment have a history of trauma. So I don't think that's surprising from what Ned has told us already and from what we know about trauma. I used to work in the prison system as well, and we know that around 90% of women in prison have a background of trauma. So it's really traumatized women that are then being locked up in prison. So this is just an interesting model to kind of know about to further your understanding around trauma experience. So if someone, for example, has experienced neglect as their trauma, they're self-medicating then with methamphetamine, for example. Methamphetamine can lead to further trauma in their life. So then they might experience homelessness because of their methamphetamine use. And then they reinforce this cycle. So it's really, really tricky to get out of. So again, just a little bit more to know about how does drugs and alcohol impact our brains and our the way we function and the way we think. So willpower, I mentioned here as well, is addiction isn't just a lack of willpower, it actually alters how your brain works. So some of the areas that it impacts is the prefrontal cortex, this front part of the brain, which is all around complex decision making, complex thinking, self-control. So addiction impairs that and impacts that, and then you'll see lots of poor judgment happening, and that's because of how the brain has changed. The nucleus accumbens, which is the pleasure and reward part of the brain, is overactivated, and that increases that cravings, want more, want more, want more. And that's why a lot of people will not get pleasure in the day-to-day things that they previously got pleasure for, is because this part of the brain has been significantly impacted. The amygdala is where the emotions and stress are managed, and that's that fight or flight. So if something scary happens, we're activated in the fight or flight. A lot of people with addictions will experience that quite a lot, and that can be a trigger for relapse. Hippocampus impacts our memory, and again, something we can see with people experiencing addictions. So a huge impact on how we function and how our brain works. So I've just put this up to see that recovery, there is hope in recovery and things can change again. So after 1 month of abstinence, we can see brain recovery starting in the brain, but after 14 months, we can see that occurring even more significantly. So those red parts are the pleasure and reward that I mentioned, that when people are using methamphetamines, for example, the brain is hijacked, they say. So we can't naturally get that dopamine release, the pleasure in the normal day-to-day things, but that can be recovered after treatment and therapy. So that's just represented here. So how do we support a loved one with addiction? This is a really difficult role, and it's really hard to sort of support without giving all of yourself, to support with having boundaries. And this is just some, I suppose, tips and how to help a loved one. So educate yourself like people here are doing today, understand it, read books, ask professionals, seek that extra education. Listen without judgment. So people really feel a lot of shame already around addiction. So to feel that further isn't really helpful. So you to be that open, non-judgmental person can be really, really supportive in someone's recovery. Encourage that professional help. Set healthy boundaries around, giving some support but not giving your all. Be patient and consistent. We will see relapse, as Nena mentioned as well. Relapse is a part of that cycle of recovery. Avoid enabling, which I'll go into a little bit more in a minute. Take care of yourself and celebrate small wins. So, for example, to go to a barbecue and not have a drink might not see that significant to you, but for someone who's been struggling with alcohol use for a long time, that's huge. Celebrate that one. So the difference in supporting versus enabling. So in supporting, encourages healthy choices. Enabling shields from choices. Supporting sets clear boundaries. Enabling makes excuses. Supporting offers help with recovery, and enabling covers up behaviours. So I'll give a brief example. So if I was to have a son living with me who struggled with methamphetamine addiction, and I was to let him live with me rent-free, and if he was to be coming down or had a hangover, I'd ring his work and make excuses for him. So that's an example of how he's not experiencing the consequences of his decision because he doesn't have to pay rent. So if he loses his job, doesn't matter that much. And then I'm ringing his boss and covering up for him. So he's not really experiencing the consequences. So we can still be a support without doing those cover-up tasks. So trauma-informed care, which was mentioned already, but I just want to emphasise how important this is. And, you know, I think drug and alcohol services in WA are pretty good at having this model in place, but it's so important. It's huge for someone to step through the door of a service and go, I need help, I want some counselling. And for the receptionist even not to understand these things is really important. They need to be welcomed into that service. They need to feel safe. There needs to be transparency around, if I write notes, where will they go? Who will see them? What will happen to that? We need them to feel empowered, for their voice to be important, you know. And one of the ones that we're hearing more and more about is this peer support. So actually peer support is found to be extremely helpful in recovery from addiction. So not just to have professionals there as support, to be able to reach out to peers. And we see that in group recovery as well, for peers to be running group recovery groups, which is great. So where can you get support? So Wanda Green Book Resource is a fabulous website. So if you go to that website and type in rehabilitation, for example, or counselling, it'll come up with a list of all those services in WA. So it's a really great one. So just to go through, so there's a phone and online support through the Alcohol and Drug Support Line. That's 24/7. So you can phone up them, have support over the phone, but you can do a live chat too. So if that's too confronting for people, they've got the option of doing the live chat. There's also a phone support for family and loved ones who are supporting someone with drug and alcohol. So it's recognised how hard that job is. So they've got the option to phone for support as well. Withdrawal management. So in East Perth, for example, there's an inpatient unit where someone can go and do the withdrawal with a team around them to support them with withdrawals. Or there's the option of a home-based withdrawal. So if someone doesn't want to go into that setting, they can have professionals come to their home every day and help them with withdrawals as well. Counselling and outpatient services, so individual, group, family and couples therapy. And that is a free option across all of Perth. It's the Community Alcohol and Drug Service, and that's a fantastic option for family members as well as for the person experiencing addiction. So that's self-referral. So Hollyoake, Wingening, Palmerston are some examples of those services. Residential rehabilitation is an option. There's also public options as well as private options for that. Transitional support and aftercare. So when someone leaves rehabilitation is a really risky time for them. They might have learnt lots of really good skills and managed really well rehabilitation, but when they go back into the community, it can be a really high risk time for relapse. So they've got this team coming in and giving them that aftercare and support in the home. Pharmacotherapy program, so that is medications to help with withdrawals, and that one's through the likes of Hollyoake Next Step as well. Justice-linked programs and drug court, so that's if someone has an offence and are in court for a drug-related offence, they have the possibility of going through drug court where they can seek support rather than potentially a criminal sentence. They can get drug rehabilitation support instead of that. Through care in prisons, where drug and alcohol support go into prisons and provide counselling and support. And harm reduction is massive. So harm reduction across WA is the safe use of needle and syringes. So being able to go in and get clean syringes to encourage safe use. And sober and up centres are a safe alternative to being in custody as well. So as I say, that is a really great resource to go into Wanda and to be able to seek support. So if anyone is looking for support, it's just really clearly laid out in there what they want to find and what options are available in which areas across Perth. So I would highly recommend that. Okay, and thank you for having me.
Thank you very much, Orla, for that very informative presentation. I'm sure everyone's taken a lot from that. And if there's parts that you think, oh, I wish I'd remember that, but I've forgotten it, you can always tune into Mind and Soul Matters podcast, and it will be uploaded in a few weeks to take more of that in. Now, our next presenter, who was supposed to be here, Phil, is not here because his wife has gone into emergency cesarean and is having a baby. So, we were very lucky and fortunate because our third presenter today sitting on the panel, Panis Zarandian, accepted to present 5 minutes ago. So thank you, Panis. She has extensive experience. I will give an introduction to Panis. Panis has a Bachelor in Criminology, Justice and Psychology and a Master's in Counselling and Psychotherapy. She has worked as counsellor educator for the past 3 years in the justice sector, running addiction programs and individual counselling. She works across the prison system from minimum to maximum security, and as mentioned, she does the group work as well as individual work. So we look forward to hearing what Panis has to say in the 5 minutes that she has had to prepare for today. Please help me welcome Panis Zarandian.
Hi everyone, thank you. So I haven't had much time to prepare, but I'm just going to speak on my experience as a counsellor. So I've worked for Serene House for the last 1.5 years, and Holyoke 1.5 years before that, just providing counselling support for women and men going through addiction. So like mentioned before, people don't start using drugs for the sake of using drugs, they use it to cope. And a lot of the people I've worked with have struggled with addiction, across all areas of their life. So from the last 6 months, I've worked with men specifically, and they've been, struggling to get the attention of support within the justice system because of the lack of funding provided. So that's something that we've been struggling to get support for. But luckily enough, our company has been branching out, trying to reach to get that support. I don't really know I'm open for questions, and I wasn't very prepared for this, so I'm happy to ask and answer any question that is, A lot of the people I work with have had that adverse childhood, so separation, witnessed in a young age. Like I would say 4 in 5 women that I've worked with have experienced domestic violence. A lot of the people that are in prison are there because they're supporting their drug habit, and homelessness is such a big issue as well. Like for the women, they seek getting into prison because they know it's a safe escape, and they know that they can get away from all the drugs and all the, bad influences in their life. So that's something that I've witnessed. Yeah. It's across all, like I would say from 18 to 70, 80, like majority of the population would be like in their early 30s. Obviously, going through different experiences, a lot of older people as well, like when their children leave the home, needing some, something to do, and they end up falling into these bad habits, unfortunately, to, cope with that.
Changing a bit more towards that stuff, because like it's not a punishing place rather than doing that whole thing and it's the relapsing, and that's a lot better.
Well, relapse is very normal in recovery. Like we say 90% of people will relapse within the 12 months because they don't have the skills to cope. They don't have the, support. A lot of people lack that support. So look, cost of running,
Put that into, making them
like Scandinavian way of doing things
Mm.
rather than that punishing.
I can speak to that. I think we're a long way off that. I think the
Yeah.
models of care in Scandinavia are miles ahead of WA. I think we have a long way to go to get there. But I think one positive is that there is a rehabilitation option now. So it's a prison, but it's a rehabilitation
Yeah.
prison, which is an option. I think it's really tricky because it's really hard to do trauma-informed care within it's still a prison system. How therapeutic is it? But I think it's a step in the right direction.
Just before we go to open up for questions, that kind of format, we just need to use the microphone because of the recording. So before we go into that format of the question and answer, I might just ask Ponies a couple of questions that relate specifically to her field, and then we'll open the floor, if that's okay with everyone, to question and answer from all our panel members, if that's all right. It just makes it simpler for the recording and for uploading this forum later on, if that's okay. So I was just wondering if, Ponies, you could share with us the programs, the education programs that you run, what do they focus on to go from the stages of change that was mentioned before, so that because I imagine people that are in that system might not be ready for change. So what does the program look like that leads hopefully to that change, and what has been your observation in terms of some of the challenges for people engaging in that, and what has been some of the rewarding aspects of it?
Alrighty, so in terms of the program, Serenian House, the DAP program mentioned before, runs a 12-week psychoed program. And this takes participants or prisoners coming up for parole. And so they are provided 12 weeks of psychoeducation across all stages of change. I would say in the last 6 months, there's been a lot of pushback because a lot of the participants are doing full time. And so there's like a shift in motivation to engage. So within that, we provide, psychoed about the impacts that drugs have on them and the coping skills to deal with such things like stress, depression, anxiety, all across shame and guilt. And it's, very complex, and it's like a weekly program. And they have to attend at least 100 hours of the program, if they don't reach that, then they're a non-completion. And then there's also another program I've started running, which is called Parole and Reach. So these are men that are coming out on parole. It's a 12-step program looking at morals and really challenges their values. And it's very structured and very if they don't meet the requirements, they unfortunately don't pass the step. Some may be on this step for 3-4 weeks because they're not really reaching what the goal or step is trying to get out of them. So that's another program I've been working with, which runs in the community and becomes part of their parole condition. But within that psychoed group, it's more about building those skills, because a lot of these people don't have the skill set, and therefore, not specifically the statistics, but a lot, I would say 90% complete the program. The only times that people don't complete the program is when they unfortunately don't meet the hour requirement, or they do end up using drugs in prison. So that's an issue that we're trying to face as well. Like, there's a lot of drugs going on within the prisons, unfortunately, and a lot of grief and domestic violence and risk of homelessness increases that drug use as well. Like, a lot of people, homelessness is their big issue. So they use drugs to get into prison, do crime to support their habit, to get into prison so that they don't have to, it's like a vicious cycle,
Thank you very much, Panis, for stepping in at very short notice, as I said, and giving us an insight into the work that you do. It does sound very challenging, and I think it really testifies to the complexity of addiction and substance use that we learnt the theory, but we can see that in practice, how complex and challenging it can be as well. Now, I would like to open the floor for any questions you might have. There is a roaming microphone, so if you have a question, please put up your hand and wait for the microphone to come to you. You can ask a question from any of our panel members.
I'm just curious about the how rampant or roughly how much drugs do get into the prison system. Obviously it's not meant to, but it happens. And yeah, how is it dealt with? And also trying to get the sources that bring it in cut out, when sometimes it might maybe some of the prison guards and it's amongst them, and I don't know, sort of a general, how does it work and how is the system?
So, is it working? Yeah. A lot of that falls on Department of Justice. So we are there to support people, and we are very lenient in terms of them. You know, if they say that they've lapsed or used in the prison, we tend to just, you know, work on why did they use and kind of go back and track where, you know, they could have used certain skills. And yeah, does that answer your question? Yeah.
Is it quite common?
It comes in waves within the prison. Yeah, we find that certain times of the year it comes more, hits harder than other times of the year. But from my experience, it's constantly going around. So it's a challenge that we've been trying to, battle.
I was just wondering, about something like pedophiles. I've seen documentaries where men are treated for pedophilia, and it seems as though it's a very hard thing to break. Are there things being done to help treat these people in prisons, or are they, you know, just recidivist? I'm interested.
I personally haven't worked with anyone that has experienced that. No. Yeah. From other counsellors that I've worked with as well, they obviously provide support and counselling for those individuals, and a lot of them have experienced sexual abuse themselves. So that's a pattern that we've recognised by working with people in that area. Yeah.
Nice question for you. You talked about trauma being a derivative of pain. What type of pain are you referring to? What level does it exist at? Like from childhood, adulthood, societally imposed, self-imposed? What sort of pain are we referring to?
I suppose it is a psychological pain. So they are using substances to try and mask that psychological pain. Is that what you're asking?
No, I'm just trying to get to the bottom of this idea of pain. You see, there's a pain, like, no. You also mentioned, I think, Paula mentioned something about neglect in her presentation, something that. So does it start from early childhood, for example, or does it happen, say, when they're 5, 6, they've got bad households? Or is it something that happens in the school systems, like in society expectations and how people tend to react with it? Like, no, you don't listen to mine because I'm the teacher, and therefore you get neglected in school, or you get bashed around because you're of a different community and the pain. So I'm just trying to get to The understanding of
causes?
the word is pain. Pain, something we can see. I mean, it's quite obvious in certain cases like homelessness, right? Domestic violence, right? Or any other that mechanism. So this one surfaces in some senses and you can do something. But I would suggest that 90% of the people are in pain, but they don't seek any help. And I'm trying to get to say is what exactly is it? Subservient form of a pain or not manifest form of pain, something there. How do you read
Sure.
pain as?
So I feel like that's a complex question, and that psychological pain that adults carry that leads to addictions can come, like we mentioned earlier, from childhood, but it can happen at other times. So things that happen to them in childhood puts them at increased risk. So when they have, a family where the father's been in prison, there's violence in the household, the mother has got addiction issues, like we heard in the example that, that I was saying, is those put the person more at risk of their substance use becoming a substance use, a severe substance use disorder, or as we say, an addiction. So I think it's sometimes a societal problem as well, right? So it's communities not being able to manage and it starts from childhood. If a child is very well supported in their household, they have a very strong community support. If they do experience hardship in school, for example, they're going to be more resilient and less likely to develop a substance use disorder. So that's where the childhood issues come into it. Anybody can develop an addiction, but these things make the person more at risk. And then the alternative, which was the positive childhood experiences, they actually have scales that we can use to, and many of these services, once a person comes into them, they actually do an assessment of their adverse childhood experiences to see where their risk profile sits at. If they have lots of positive childhood experiences, that provides a protective factor. So even though they might have peer pressure, they might have issues that come up for them in life, something might happen later, they're going to have more skill sets, I guess, and less vulnerable to fall into an addiction pattern. There's no hard and fast rule. It's not like they never will if they have somebody could have a very supported family, but like the stats were showing that Orla shared as well, it increases the risk. I'm not sure if Orla, you want to add to that anything as well?
I think just echoing what you're saying, and I think those examples you give, that could be painful. So I think something everyone can relate to is grief and loss. So when we experience grief and loss, that's a pain. That's a pain that we feel. So many things can cause that pain, such as bullying in school, such as domestic violence, household growing up. So all of those things, and it can be many things, collating more and more pain over the years. And as Neda said, that's higher risk to developing a substance use disorder. So yeah, has that answered your question? A little bit.
If I may reframe that question, I think it has answered it largely, but also the other side of the coin is, for example, 3 children can be raised in the same household with the same level of abuse, whether that's physical, emotional, or sexual, but 2 of those children may develop a substance disorder, but a third may not. So is there any research that you're aware of, or what is it about that third child that leads to them not developing a substance disorder?
So there's many things that we know. So that could be personality. So that person might be need less emotional support from their families because of who they are as an individual. It could be because they've got a teacher at school who gives them a lot of care and attention and one-on-one time. And research is shown to have that one strong relationship, that one strong attachment with a neighbour or whoever it is in the community can really strengthen that child's outcome to not develop a substance use disorder or a mental health disorder. So the importance of that is massive for children living in households where there are challenges. To have that one person in the community is massive.
Also to that, Gabor Mate, who I referred to earlier, speaks a lot on this, and he actually says that the siblings don't have the same parents. Parents change across the continuum. So how they were, what their circumstances were, what the environment was from one child to the next is actually different. So you have differences in the children. You also have differences in the parents. Overall, it might look like they're the same, but parents change as well. And so I think that's something to be aware of as well.
I guess my question is sort of a follow-up to that, because you said trauma is a big factor in addiction, and it might not be a simple answer, but at what point this idea of breaking the cycle, is it doable? Is it easy? Before you get into that habit, how do you identify that before you become like go to the cycle of addiction?
I think lots of things, right? It's a community response that we need to have, providing safe spaces and environments. It's recognizing people or children maybe in the early stages who might be at risk and offering that extra support to them. And then recognizing those things as community members, but in general practice. So in general practice, we're seeing a whole cross section. By the time they've actually entered the prison system or an addiction service, one, they're already, like you say, experiencing the problems of addiction. And secondly, they're also, I might say, at the stage where they're ready to make a change sometimes, not necessarily in the prison system, but sometimes they're actually at that stage. So we're trying to see maybe in the community or in general practice, how do we find them in that earlier stage before they're, or how do we identify them and help support them? I do think, one of the big things is there is always hope for recovery. There's always hope to change. And I think, giving that hope to friends, to family, or to people in the community, that just because you're using now doesn't mean you always will. Just because you've relapsed, you were using and now you've relapsed again. It's not the end of the world. It's actually turning that to a positive and reminding them that people who are actually successful and like quitting long term are actually needing to go through that. So every time you go through it, instead of thinking of it as a failure, thinking of it as as this is part of the step. What are you learning from this? What happened that you relapsed? Let's explore that, because that's going to be really good learning for us to try and stop the next relapse. Is that you want?
So just adding on to what you said about early intervention programs are huge. So that's some of the stuff I'm doing around baby massage, around avoiding trauma. So we know 1 in 3 women in Australia experience trauma in birth. So by doing hypnobirthing programs to go, right, let's give that education and let's try and avoid that additional trauma. So it's huge, and we should be starting with babies. So we know that a baby has a parent with an addiction who has a substance use issue. There should be supports and help going into that home from day one to go, they've got lots of adversities here. We need to put things in place to sort of avoid them ending up, down the same track or with the same challenges that their parent has had. There are some programs like that. There's not enough. There's not enough funding out there. I do feel hopeful that schools now have more psychologists, social workers and supports in schools, so that once, smaller things come up, we can go, right, okay, our mum and dad separated, let's check in with that child, before that sort of maybe escalates into other things. So I think that's hugely important. I think we as parents and grandparents and community members also can model things like you mentioned, how to manage stress, how to manage anxiety, depression, talking with our children about those things and teaching them the skills so that if they do face that down the line, that they sort of know how to start to navigate that, or at least know that they can come to us and go, that thing you talked about, I'm struggling with that.
These days, there is a lot of corporatized medicine where you don't have a family GP to recognize early symptoms. How can sort of a patient discuss the sort of issues with corporatized medicine to be able to receive care?
The difficulty is, picking up and the patient trusting the person that they've gone to disclose. And I use the example that even with that continuity, it took that particular patient a long time to feel safe, to trust and disclose what was actually happening and what the background was. I think it's a challenge we have as a community. Our health system, has got challenges. It needs to be a community-wide effort. So everybody, regardless of their place in the community, can look for signs in people. If you see someone is more irritable, they seem to be struggling, we know that it's a single parent, we know that it's a person who's going through a bit of a tough time, we need to check in with them. It's all of our collective responsibility. And not to give up. So you encourage them to seek help from a professional, even if it is the first time they're seeing them. I have also had patients who come in for the first time that I have never met before, who just come in that first consult. You can disclose, and they can, disclose to you what's happening, or they can start asking for help. And also just, asking questions from the patients. And I think doctors, hopefully, depending on what's happening, in their day potentially, but they are good at actually seeing a new patient and asking generally what's going on and getting their story and maybe pinpointing, what's happening with, what drug use are you having, making those questions more, readily or easy to ask. If you easily ask those questions, you'll be surprised. Sometimes, they do disclose to you. I don't know what other community.
Yeah, I was just thinking as you were talking about, so I worked at Netta's practice for a while, and I think what I observed there was the challenges that there are for GPs around this short time, right? So Medicare allocate you this short amount of time, and GPs are working way over that and not getting paid for it and whatever else. But they care, they just don't have the time, and the system's not supporting them to do that, which is a shame, and which there's definitely room for improvement in supporting GPs to be able to do that really thorough in-depth assessment and to be able to have that time to build that relationship with you so you feel safe to disclose, I think.
Thank you. We might take one more question.
Hello, it's not a question. It's just I'm getting back to what my husband asked before about the pain. And I think people think pain as something which they've experienced because of the cut or because of heart attack or because of pain in the abdomen. But the person who suffers from neurological disorders like substance abuse, anxiety, and depression, their pain is a different pain. But the word used for the symptoms or the sign is pain. And pain, the definition is an unpleasant sensation. So unpleasant sensation because of your thought wave process, which is deranged in people with substance abuse, is also a pain. And the pain, when my husband asked, probably because he had experienced a bad pain, so he thought maybe they have a pain when they have this. But no, for the other people also, and as far as you're a doctor yourself, so all these substance abuse patients, they have a first instant of some thought coming to use these substances. So for them, it's a pleasure and it becomes a pain. And all the supportive people and all the social workers and the communities which are treating them, they're trying to alleviate their pain by changing the thought wave process and bringing it back to normal. That's what I just wanted to confirm, because I knew we will have a debate when we are going back home. It's fine.
Thank you very much for clarifying that. We will take one more question just at the back.
Can I just respond to that? I think you explained that really beautifully, because we know that people who have a habit of any type, their brain has a pathway, right, that goes, this is what we do, this is what we do, and it gets stronger and stronger and stronger, this pathway, and then we try and do a new pathway. But if you walk in the forest once, the trail's not very deep, okay? You need to keep walking that pathway to strengthen it and to make the other one weaker, right? So you need to do something a lot of times for that to really be ingrained in us. And yeah, thanks, you just explained that. So
it's the mind which causes the problem. It's the mind which is going to treat it.
yeah,
There is no difference. It's better to treat your mind by yourself or by oneself.
Thank you. Thank you. We'll have one more question. Just we'll make it brief so that we have time for refreshments as well.
Sure. Hi, thank you to all the presenters. My question is, in my field of work, being a pharmacist, we participate in the community program as far as the medication, the place of medication goes to help with the addiction and, stopping cravings and things. What we see is, unfortunately, there are not enough prescribers who can support the system in that sense. Not a lot of GPs would like to do the program and participate in it, so it's not as readily available. There's only particular centers and they are completely maxed out. So I just wanted to ask, what are some of the challenges or some of the reasons why GPs hold back from participating in the program, and what you think the place of medication would be for this?
Those are very good questions, and we do have a shortage of providers in the space. It's very challenging work, and it's very time-intensive work. And I think Orla also mentioned about the time constraints that a lot of people have in their practices. It can easily become the only thing you're doing. If you're a prescriber, you will suddenly find your practice can shift to being just dealing with substance use disorders. And I think that, is a whole area unto itself that can be, you have to make an active choice that you want to be doing this for your work, because doctors are also trying to deal with a whole range of different things, but those particular patients are going to be taking up a lot of time and energy, and going to need increased expertise. You're going to need to upskill in those areas. Orla actually touched on the fact that she was in the clinic, and I think having multidisciplinary teams will help address that. And we're starting to make that shift in general practice to try, and government is trying to make that shift to actually fund different types of service providers to work within the general practice setting. Certainly the time when we had Orla in the practice, having that skill set there made it easier to manage some of these patients, because we had the extra support there that could help with the care of patients. But it's a system-wide problem, and it probably needs a lot of change along the way to be able to address it. But at least we're becoming more aware. We're heading in that direction of trying to deal with it. And it's going to be a whole community effort, like mentioned before. It's not just one segment. It's not just the drug and alcohol services or just the GPs. It's a whole community-wide effort that we need to have to make the changes.
Thank you very much. Thank you very much. I think the discussion today has really illustrated how complex substance use and addictions is, and hopefully, well, I'm sure it has enhanced all of our understandings to some extent, and there's always more to learn and more conversations to have. So I'd like to say a big thank you to the Baha'i community of Melville for hosting our expert panelists, especially Panus, who stepped in the last minute, our AV guys at the back who do the recording and provide live stream, and the Mental Health Forum organising task force. If anyone is interested in continuing this conversation, we have our psychologist, Miss Sarah McFarlane, who's waving there. She will continue this conversation in smaller groups. If you're interested, just meet her in the foyer at 4:30, which is in about 10 minutes. Also, we have the bookshop open, which is also to the right of the foyer, if you would like to purchase any books or get any more information. And we also have some resources out at the back on the table. And you have, when you sat down, you would have found some resources on your chair, which you can use to continue to increase your understanding of addictions, or to share with friends and family who might be supporting someone through addiction. If you would like to have more information about upcoming events or the next forum, keep an eye out on the Melville Baha'i Instagram and Facebook. And our next forum will be held on Sunday, 21st of September, slightly different time from 10 till 12, and it will be on understanding Alzheimer's. Thank you again for being a part of this important conversation, and please join us for refreshments.
It was meant to be funny. Do I unplug these? I have no idea.